And now we're going to bring Doug back up for a state-of-the-art lecture. Here we go.
Okay, great. So again, thanks again. It's really my pleasure to be here. It's been wonderful. As I mentioned, we have some relatives in the area. It's nice visiting. And again, this has just been an amazing vista and time to spend here. So my talk is entitled Open Questions in Colorectal Cancer Screening. My disclosures are shown here. While it's entitled Open Questions in Colorectal Cancer Screening, I'm actually going to give you a freebie. So I'm going to do one closed question, which is, does colorectal cancer screening work? With the idea of educating and trying to get some basic epidemiology into the talk. And then move to the open questions, which include, when do we start screening? And we already started talking about that a little bit, which is great. Which test is best for colorectal cancer screening? Maybe that's something that's a closed question for you, but it's clearly an open question for me. And so maybe I'll try to convince you why it's an open question. And then finally, what is the future of colorectal cancer screening? And Bill actually presented one of these, emerging blood tests. And I think there's a lot of interest in that. And so I'm going to try to briefly cover some of that as well. So I'm going to start here. I noticed there's a talk, I believe by Dr. Canto this afternoon or later today about screening for pancreas cancer. We talk a lot about screening for these diseases in the United States, but I wanted to remind you that that's really hard to do, right? Screening populations make sense only when the target disease is common in the associated population that you're looking for it in. Remember, in the United States, right, we're looking for it in like the entire adult population. So it's got to be common in that population. It's got to be associated with a high morbidity and mortality. And then again, most importantly, and I always think about this with pancreas cancer, does it have an identifiable and treatable preclinical phase? But I think as someone who studies colon cancer, right, I have a relatively easy job. I think colorectal cancer meets all those tenets. So it's common and it's lethal. I'm showing you here relatively recent data about mortality from colorectal cancer. It's the third most common cause of cancer separately in men and women. Overall, it rises to the second most common cause of cancer death in the United States. So common, lethal. Again, I'm gonna spend like 2 seconds on this panel, right? We all know that finding disease early makes a difference in colorectal cancer. Much rather be diagnosed with a local cancer than a distant cancer. But again, just reminding ourselves, we focus a lot on polyps, but a big way that screening works is finding cancers early, because the marked difference in outcome when you find early cancer. And then finally, we do have this thing that we take a lot of pride in. The idea that we find and remove polyps and have the potential to actually prevent colorectal cancers. And so certainly colorectal cancer meets these three tenets. Now, you probably know that colorectal cancer gets a grade A recommendation from the US Preventative Services Task Force. And it's not because colon cancer meets these tenets of screening. The reason why the United States Preventative Services Task Force gives colorectal cancer screening a grade A recommendation is because we have developed, and I think we should take great pride in this as a subspecialty, incredibly strong data that colorectal cancer screening works. And I often talk to the residents and the fellows, and I ask them this question. They're always unsure, at least at the beginning of their fellowship. Do we have randomized control trial evidence that colorectal cancer screening works? And the answer is we do. I'm just showing you the two large US trials, right? These trials were done years ago, reported years ago. The top line is the Mandel study, a randomized control trial of fecal occult blood testing in 46,000 individuals that showed being in the FOBT arm relative to the usual care arm was associated with a 33% reduction in colorectal cancer mortality. And then the Rocky Schoen flexible sigmoidoscopy trial, that's part of the PLCO trial, right? Prostate, lung, colon, and ovary. So C is the colon. So they reported these results now, again, hard to believe, 10 years ago, in 154,000 folks being randomized to sigmoidoscopy as opposed to usual care was associated with, again, close to a 30% reduction in colorectal cancer mortality. So again, it's a closed question. Colorectal cancer screening works, and we have grade A evidence to support it. So let's move to the open questions. When do we start screening? And this slide's been in my slide deck for a while. The guy says I've turned 50 and I'm depressed. And he says, so it's probably not a good time to tell you about colonoscopies. But this slide has become a little bit dated, right? This isn't quite the right interval anymore. And so I want to spend a few minutes thinking about in detailed fashion how we moved from these 2016 United States Preventative Services Task Force guidelines that recommended starting screening at age 50 to the 2018 American Cancer Society guidelines that gave a qualified recommendation to start screening at age 45, right? So how did we go from this to this? What was the factor that resulted in this move to the 45-year-old screening age? And so you probably know the basis of these recommendations, be it the US Preventative Services Task Force guidelines or the American Cancer Society guidelines, are these models. We have these very well worked out models, including, and again, maybe you've heard these terms, the SIM-CRC, the MyScan model, the CRC spin model, that have been validated against real world data. And it's these models that drive a lot of the recommendations from these major evidence-based organizations. So the models didn't change between 2016 and 2018, but the inputs to the models changed. That's what drove those changes in recommendations. So to understand that, you need to understand what's shown on this slide first, that generally speaking in the United States, colorectal cancer incidence and mortality is a good news story in a way. The rates of incidence and mortality have been falling, and they're falling for many years. And so this is taken from a perspective piece I wrote with Gil Welsh many years ago. And again, this is showing incidence, but if I showed mortality, it would show the same trends going in the right direction. But what's hidden there is the difference in those trajectories for folks of various ages. And so I'm going to briefly fill in this table that shows colon cancer rates in 1999 and 2019, rectal cancer rates in 1999 and 2019, stratified by those age groups that you see on the slide. So if you start down at the older ages, you see all the good news story, right? You see that rates of colon and rectal cancer in those two age bands are falling. And that's why I've put those rates in green. In the 50-59-year-olds, a little bit of a mixed story. Certainly the more common colon cancer rates are falling, but the rectal cancer rates were actually going in the opposite direction, where rectal cancer cases were increasing from 1999 to 2019. And again, in the most pronounced way, you see that in the 45 to 49-year-old age, both rates, both colon cancer, more common colon cancer, and rectal cancer are going in the wrong direction. So it was updating the models with this age-specific data that led to the new conclusions of the American Cancer Society initially. And again, you're probably seeing this last year because they basically play off the same sheets of music. The United States Preventative Services Task Force has moved to basically a same structure. They recommend in a grade A way, screening from age 50 to 75. They give a grade B recommendation because of the lesser evidence in the 45 to 49-year-old range. And again, grade C for 76 to 85-year-old. And then finally, and maybe last to the party in a way, is the US Multi-Society Task Force, which is this task force composed of 3 representatives from the AGA, the ACG, and the ASGE. And we just in the last few months published our updated screening guidelines. And we too now suggest that clinicians offer CRC screening to all average risk individuals age 45 to 49, but do realize that that's lower quality evidence. And then if you don't get screened in that age, a strong recommendation to start at age 50. So why is this still an open question then, right? This is the title of this thing is open questions. I just showed you the data and I'm suggesting, all these guidelines have, moved to this younger age range. Well, I think it's an open question for a couple of reasons that I'll review here. Something about the strength of the evidence, something about the numbers themselves, and then the downstream implications of this recommendation. So what about the strength of evidence? And again, maybe this is the one you're least interested in, but the fact of the matter is that, I showed you these randomized controlled trials. I didn't show you the age range of the people that were recruited into those trials, right? None of the people were 45 to 49. So while we have great evidence about this older adult population, we don't have the same level of evidence in the younger group. Now you can argue, why would it be different? Well, it could be different, right? Cancers in younger folks biologically could be different. There's actually some evidence that these cancers are more aggressive in the way. So maybe screening doesn't work as well in younger people. So to the extent that we've changed these guidelines, we start screening everybody in this age group, we really don't have an opportunity to build that data set. But again, maybe more of an academic concern. The second idea is just this numbers game piece of this. So I've already shown you this slide and I tried to kind of bamboozle you with the colors and everything, but why don't I simplify the slide a bit, right? Let's take off those funky colors and let's get rid of 1999. Let's just focus on 2019. And what you could see, right, is that the likelihood of getting cancer is so much greater in these older age ranges, both colon and rectal cancer. Like the rates aren't even close. 90% of the cancers are occurring in people 50 and older. So again, why should we be moving our focus to these younger folks? But maybe even this is too kind of relative for you. So I really want to give you a real feel for the numbers. Just before I started the talk, someone was asking me this question and really wanted to kind of dig into the absolute numbers themselves. So how much benefit do you get by starting screening at age 45 instead of starting at age 50? And so this is pulled out of the JAMA paper that kind of goes along with the recommendations. It's like, there's like hundreds of pages of modeling, but again, some of the main models are in the reference shown here. And I'm going to take you through this slowly. I'm going to show you slides like this a couple times during the talk, so I'll go more quickly. But basically, I'm going to tell you about the benefits and harms of starting at 45 instead of 50. And so the benefits are measured as the estimated number of colorectal cancer deaths averted per 1,000 individuals screened. And I'm just going to focus on that colonoscopy strategy that you're all very familiar with. So how many deaths do you avert per 1,000 people if you start screening at age 45 instead of age 50? Well, you see it there. 1 death per 1,000 people. The vast majority of the benefit is coming from screening over age 50, right? The 27 there. So you avert 1 extra death by starting at age 45. So relatively small, but 1 per 1,000. Now, how much extra work do we need to do by colonoscopy to prevent that 1 cancer? Well, that's shown in this table. So in 1,000 folks, you need to do 784 extra colonoscopies to prevent that 1 cancer. And so in 1,000 individuals screened by a primary strategy of colonoscopy every 10 years, you can avert 1 death by starting screening at age 45 at a cost of 780 colonoscopies. And remember, I'm going to show this in a second. I mean, the vast majority of people are never destined to get colorectal cancer. They can only be harmed by screening. And so again, you're doing a lot of extra colonoscopy to prevent 1 death. I think that's why it's still a little bit of an open question. And then finally, the downstream implications and equity. And here, I would just refer you to this paper by Peter Liang and colleagues, very well done study. And they did focus on the fact that we can't study it anymore, but this idea that we're diverting resources to lower risk populations. A very thoughtful question was just asked a few minutes ago. It's kind of along these lines, right? I mean, who do you think is coming for screening at age 45 to 49? Right? I mean, we have a major discrepancy in adherence between people who have insurance in the United States and don't. I mean, we're getting close to the 60 to 70 range for people, 70% of the population screened if you have insurance, somewhere in the range of 30 to 40% if you don't have insurance in the United States. And so there's the possibility that, again, putting our endo suites, screening more 45 to 49-year-olds is only going to increase this level of disparity. So what's the take home here? And again, I already mentioned one of the take homes. I mean, what do you do with this information? How do you make it actionable? Well, I do think we need to enhance our approach to case finding, right? If we're going to recommend screening in 45 to 49-year-olds, I think we have to have a very low threshold of scoping people with symptoms, even in younger age ranges than that. And I think when I was a fellow, we'd struggle with someone with, 30, 35, 40 years old with bright red blood, and maybe we'll do a flex sig. I think those days are over. I mean, I do think, given the recommendations, given the concern about early onset cancer, I do think being aggressive about case finding is important. And then the last thing I would simply say is something about family history. And there was a very nice paper, if you haven't read it, by Frank Sinecrope in the New England Journal, just recently published, where he points out that nearly 30% of patients with early onset colorectal cancer have a family history of CRC and at least 1 first-degree relative. And so this idea of being much more cognizant about family history, now to a certain extent, it's kind of difficult for us as gastroenterologists, right? I mean, a lot of the cases that we're doing are referred to us. So in terms of this extra questioning about family history, that has to be happening at your primary care practices that are referring folks to you. But the people in this room are thought leaders about colorectal cancer. So encouraging them to up their game, thinking about family history and risk, I think is really important. I think the other thing that we can do, and again, my guess is that many of your medical centers where you work are already doing this, but this idea of universal testing of newly diagnosed colorectal cancer via MMR and MSI to enhance detection of Lynch syndrome. You know, we do, this is a recommendation by the NCCN that we do this kind of testing. So I think upping our game in terms of doing this testing will help us find these Lynch families sooner and help get at some of this early colorectal cancer risk. So those are some actionable items on this when to start screening question. All right, so maybe this is the point where people are going to go out and get some coffee or get ready for their lunch, but I am going to take on this idea of which test is best for colorectal cancer, which is always difficult in a gastroenterologist, largely gastroenterologist audience, but I am going to take this on. And to get you interested at all in the comparative effectiveness data, I'm going to show you, I think I at least have to sell a little bit, like why colonoscopy might not be the best test. And again, I'm a gastroenterologist. I like doing colonoscopy, but why might it not be the best test? And so the reasons are summarized here. It's something about risk benefits. Believe it or not, it's something about polyps. And again, it's this recognition that colonoscopy is an imperfect gold standard. So I'm going to start here, and this again helps me talk about epidemiology again, but you know, we got a lot of talent in here. If we went and scoped, and again, this is like a thought exercise, if we scoped 100 people who are at average risk for colorectal cancer today, combining our resources, and they roughly represented the US population, I mean, how many people could benefit from that exercise? How many people benefit from undergoing a screening colonoscopy? And so it has something to do with the lifetime risk of colorectal cancer, right? And you're probably familiar with this number, right? The lifetime risk of getting colon cancer is somewhere between 4 and 5%. The lifetime risk of dying from colon cancer, shade less than 2%. So colorectal cancer is common. It's lethal. It's the second most common cause of cancer death in the United States. It has a grade A recommendation for screening because of this randomized evidence, but it's not that common. And it's not that lethal. The vast majority of people who get screened are never destined to get colorectal cancer. So they can only be harmed by screening. Again, this is not an argument not to screen, just puts in context how difficult it is to screen. And again, I think colon cancer is probably one of the only diseases where we start with the most invasive test first in the United States. So does that make sense? Second thing is something about polyps. I've already extolled the virtue of polyps. We can interrupt the polyp cancer sequence, but the fact of the matter is it's not a great surrogate measure for cancer, right? And I think you all have a feel for this now. We have this aspirational ADR of 50%, like 50% of the average risk population has one or more adenomas. And again, I used to show this study as well. This was a randomized controlled trial comparing chromocolonoscopy and white light endoscopy, but simply shows that high quality white light endoscopy finds polyps or adenomas in folks 50% of the time. So if 50% of the population has one or more adenomas and like 5% is getting cancer, the vast majority of people with adenomas also are not destined to get colorectal cancer. And then the final thing is, I think you all recognize it's an imperfect gold standard. Very briefly, this is a paper I published in Gut now 8 years or so ago, where we pooled data from 8 large North American studies, about 9,000 individuals, where everybody in those studies underwent complete clearing colonoscopy, removal of all visualized lesions. None were felt to have colon cancer. They all had specified follow-up in the next year, next few years. So a mean follow-up about 4 years. And in that study, 58 of the folks were detected with cancer out of the 9,000. Now, again, this is older data. This includes data from the old Dartmouth polyp prevention trials. It includes the National Polyp Study. I suspect we are doing much better colonoscopy than we were back then. But again, I think this does open the door to thinking about other screening modalities aside from colonoscopy. It's also a call to arms to up our game to do the best we can with the tool that we do control and is the final common pathway for all these non-invasive tests. All right, so let me pivot a little bit and just talk about some very briefly effectiveness and comparative effectiveness data. This, I am not going to spend time talking about CTC and FlexSig. But I am going to spend some time just briefly talking about FIT, stool DNA, and colonoscopy, because I think those are the tests that people are routinely getting done. So again, I don't know if there's fellows in the audience. I assume there are. I mean, if someone asked you as a fellow, how effective is colonoscopy in preventing colorectal cancer? It's an interesting question to answer. We don't have randomized controlled trial evidence. What we do have is a bunch of cohort studies. This shows 4 US cohort studies that tell a pretty similar story. Colonoscopy is associated with somewhere around a 60% reduction in colorectal cancer mortality. Now, again, you can't compare that to the randomized controlled trial evidence I showed you earlier, but this is observational data with all the flaws of observational data, but about a 60% reduction in colorectal cancer. So what about FIT? If you're interested in FIT, I wrote this paper for the USMSTF a few years ago. I still think a lot of the data is relevant and current. But I think the question I really want to answer with this, one-time FIT, how often does it detect cancer when it's there, right? You have a feel for it with colonoscopy. It's probably in the mid to high 90s. What about FIT when you do one FIT? Well, we have meta-analysis, and meta-analysis suggests that the one-time sensitivity of FIT, as we generally use it, has a sensitivity of somewhere between 75 and 80% with a specificity of about 95% or so, about a 5% false positive rate. And then finally, multi-target DNA test, right? You can't get away from it. If you watch TV, there's commercials all the time for it. Just a reminder that the multi-target DNA test is really 2 tests in one, right? It's the combination of these methylated genes. And so the person collects a whole stool sample, sends it off for those methylated gene markers and KRAS, but they also poke the stool with a fecal immunochemical test before they mail it off. And then the company does the gene testing, does the blood in the stool testing, and then does a logistic regression and tells you positive or negative. And so just a reminder, it's kind of like FIT plus more, right? So what would you expect a FIT plus more test to do? Well, you'd expect it to be more sensitive and less specific, right? More false positives. And so that's exactly what the data shows. And so you've probably seen this. This is this classic kind of registration trial in 10,000 individuals comparing FIT and the multi-target DNA test in 10,000 individuals or so. And what you see on the left is that the FIT DNA has a 92% sensitivity, one-time sensitivity for cancer, a 42% sensitivity for advanced precancer, and a 42% sensitivity for sessile serrated lesions as well. There's actually these methylated markers that are kind of an enhanced way to pick up these serrated lesions. And so it does detect serrated lesions fairly well. You could see FIT performed about the way you think FIT would perform. I just showed you a meta-analysis where the sensitivity of FIT was around 75% or so, and it was 75% in this study. FIT detects advanced adenomas less well, 24% as a one-time test, and then sessile serrated lesions, 5%, really the level of chance. But again, the flip side here is the specificity. There's going to be a lot more false positives with the multi-target DNA, so about a 13% false positive rate as a one-time test relative to about a 5% false positive rate with FIT. So that's kind of like one-time effectiveness data. But I want to close this section thinking about comparative effectiveness, right? What do we find when we compare colonoscopy and FIT head-to-head, or the multi-target DNA test and FIT head-to-head? And I'm going to use that rich data that I've already shown you from that Davidson paper, from the United States Preventative Services Task Force paper. So let's first look at the comparison between FIT and, again, programmatic FIT, right? This is not one-time FIT anymore, programmatic FIT versus colonoscopy. And so I've already kind of shown you these slides, but I'll take you through it again. So the number of colorectal cancer deaths averted, again, I'm going to use the starting at 50 since that's where most of the benefit comes. I'm trying to get my cursor here. You could see that a strategy of colonoscopy, and again, this is summarizing all 3 models, SIMCRC, CRSPIN, and MISCAN. You could see that a strategy of colonoscopy every 10 years averts 27 cancers per 1,000 individuals relative to 25 in the FIT arm. So you avert 2 extra cancers by starting with colonoscopy first. But of course, that comes at a cost, right? You're going to do more colonoscopies to get there. So just how many more colonoscopies that you have to do? And that's shown here. You have to do roughly 2,000 more colonoscopies per 1,000 individuals to get that extra 2 cancer reduction. Now, again, this is modeling, it's making assumptions about adherence that are not real world assumptions, but this is the best evidence. This is what the USPSTF is relying on. So the summary of this is that in 1,000 individuals, the strategy of colonoscopy relative to FIT averts 2 deaths at a cost of roughly 2,000 extra colonoscopies. I mean, I think you could, I think different minds will see this result differently. It's partly because of this close call, if you will, that there are 3 large randomized controlled trials comparing colonoscopy and FIT. I already told you about the CONFIRM trial, which is the US trial. There's also the Coloprev trial, the SCREESCO trial. They're comparing FIT, or they're using FIT slightly differently biannually. We're using it annually. But in any case, these results will be coming out, I would say, in the next near term, in the next few years for those European trials. Again, we're a little bit farther back, about 5 years from now. And again, if you're interested in CONFIRM, I'm not going to go any more in detail about it, but I did put a link to our methods paper there if you're interested. Finally, in this section, I'm going to go to the last section, is just the FIT versus multi-target DNA comparison. Because again, I think there's a lot of interest in mtDNA. So let's do that same exercise. If you do mtDNA every 3 years or FIT annually, what's the difference in benefits and harm? So this may surprise you based on the one-time data I just showed you, but because of the repeated application of FIT in these models, FIT actually averts 1 extra death than the strategy of the multi-target DNA test in the US preventative services modeling when you're applying the multi-target DNA test every 3 years. And what's the benefit? What's the harms? Well, there's almost no daylight between the number of colonoscopy tests you need to use to accomplish that gain. So to summarize, in 1,000 individuals, a strategy of FIT relative to mDNA averts 1 death at a cost of roughly 20 extra colonoscopies. So my last slide is essentially this one. Again, I think you could look at that colonoscopy versus FIT data comparison. Again, different minds might have different thoughts, but I do think, again, the models would suggest that FIT's actually a more effective strategy than the multi-target DNA strategy. And again, I'm just showing part of the modeling. You could take a look at the hundreds of pages of modeling, but I think it's pretty clear that at least based on the modeling uses and these adherence assumptions, FIT is probably a better strategy. All right, and then finally, I'm just leaving you with the US MSTF guidelines that we recommend colonoscopy and FIT as first-tier options. But of course, the important message is that the best screening test is the one that gets done. So maybe what you're most interested in is something about the future of colorectal cancer screening. So I'm going to finish up with that. I'm going to talk about 3 different ways that I kind of see the future of colorectal cancer screening in the United States. One is something about modifying our current screening tests. Second idea is something about modifying our approach to current screening tests. And I think Dr. Dulai has done a good job starting us to think about personalized screening. And so I'm going to talk a little bit about personalization of colorectal cancer screening. And then finally, just a little bit about the new tests that are on the horizon. And again, we heard about an abstract earlier today related to one of these blood tests. So modifying current tests, I think it's just important to point out, right? I showed you some data about colonoscopy, and I showed these 3 prospective cohort trials that suggest that colonoscopy is associated with about a 60% reduction in colorectal cancer mortality. Well, that's how we've applied colonoscopy for years. And I'm not suggesting that 100% we're going to all uptake AI into our practices, but I'm suggesting that our modalities, our current screening modalities, are not static modalities. And so again, you've seen this slide already. It shows the meta-analysis comparing AI colonoscopy to controls. And it shows that applying AI, increases the detection of diminutive lesions pretty significantly, 6 to 9 millimeter lesions, also fairly significantly. And again, this was not statistically significant increase in advanced adenomas, but I showed you that abstract that was just presented at DDW where, in about 3,000 patients, you did see an improvement in ADR. So the point here is colonoscopy is not a static test, right? We're always working to improve it, be a CAP or some kind of distal attachment device to improve visualization, or again, AI. So I think that's one way that screening is going to change. We're going to keep making our technology the best it can be. But I don't know. Yeah, I can go back one. But FIT is changing, can be changed as well, or our other screening modalities can be changed as well. And so I've already shown you an earlier meta-analysis. This is a more recent meta-analysis by Tom Imperiale that looked at FIT. And I just want to remind you that generally in the United States, we do use this 20 micrograms of hemoglobin threshold per gram weight of stool. So if any of your practices or you're aware of people using the OC sensor polymedico device, I have no relationship with them, but if you're using that platform, the built-in threshold is 20 micrograms of hemoglobin per gram weight of stool. It's the FDA cleared threshold for the test. And so what you're seeing here is the sensitivity and specificity that I already kind of showed you from the other meta-analysis. So at that 20 microgram threshold, FIT has a sensitivity of about 75%, specificity of 95%. And for advanced adenomas, you could see the numbers here. But again, we could apply FIT differently. FIT doesn't have to be applied at that threshold. You could actually tune the gain down on your OC sensor device. You could turn down the hemoglobin detection down to 10 micrograms of hemoglobin per gram weight of stool. Well, what's that going to do? Well, you're going to have more positives. You're going to have higher sensitivity, and you're going to have a lower specificity. And so in his meta-analysis, the sensitivity when you move from FIT at 20 micrograms to 10 micrograms improves from 75% one-time sensitivity to 91% one-time sensitivity with, again, a fall in specificity from 95% to 90%. So what's the point here? Is the point that we should switch? I mean, I don't know. I mean, I think that's an interesting question. But the point is, we're doing the CONFIRM trial that's comparing colonoscopy to FIT at this threshold. Maybe CONFIRM 2 is going to be AI-assisted colonoscopy compared to, FIT at a lower threshold, right? These modalities are always changing, always moving. And I would say that the future of screening continues to be really bright as we continue to modify our technologies. The second thing is thinking about our approach to current screening tests. And I do think that we are very siloed in our thinking about tests, right? I mean, most of us are colonoscopy enthusiasts. Maybe I'm viewed as a FIT enthusiast in a way, but we have this kind of very kind of linear pathway. This is how people get screened. They pick a modality and they move on. But of course, it could be much more complicated than that. The truth is, we don't use any of the information that we have. Generally speaking, we don't use any of the information we have available to us about the participant. And we know that baseline risk for advanced adenoma and cancer differs dramatically depending on who you are and what your habits are. And so this is a paper I published a few years ago with Uri Lauterbom entitled Opportunities and Challenges in Moving from Current Guidelines to Personalized Colorectal Cancer Screening. Again, I don't have the time to go in great detail, but if you're interested in this topic, I think we cover some of the ideas that I'm going to go over in the next slide, which is essentially maybe we should be leveraging this information about the patient and then picking our screening tests according to that. And so this is a slide that's entitled Risk Scores for Predicting Advanced Colorectal Neoplasia in the Average Risk Population, a Systematic Review and Meta-Analysis. And it may surprise you, maybe it doesn't. I mean, they're actually summarizing 22 separate studies that have these risk models that use things that are commonly available in our medical records, right? Like age, sex, family history, BMI, smoking. I mean, we can do this. We can see people in clinic. Again, I'm looking at the stuff that Parent Bear was doing is much more complicated. I mean, we could apply these models and figure out who's at high risk for colorectal cancer and send them to a more invasive test, and who's at lower risk for colorectal cancer and send them to a non-invasive test. But we really don't do that in the United States. So I'll leave you with this last, it's really a proof of principle study because everybody in this study to figure out the test characteristics got the definitive test was just colonoscopy. But again, the ideas of how this might work is in this paper. So they took a population of about 5,000 folks. They applied the Asia Pacific colorectal cancer screening scoring system. Again, one of these scoring systems. So when they applied the scoring system, about 80%, right? 4,434 had a low risk score. So they got FIT. And 500 of those people were FIT positive. So of course they would get colonoscopy. The rest of those people would move forward with their FIT negative result. And then 1,766 had a high risk score on that Asian Pacific colorectal cancer scoring system. So with this approach, triaging people just based on this relatively simple scoring system, they were able to identify 71% of the folks with advanced neoplasia and 95% of those with cancer. So again, I've been saying FIT, right? It has a one-time sensitivity of 75%, but if we apply it this way as part of this package, you could improve the detection up to about 95%. So again, there's not, I mean, again, I applaud Parent Bear with this website and how you can go and do this in your practice. I really don't think we're applying these kind of risk tools, but I do think that's a missed opportunity. And then finally, implementing new screening tests. So of course, the world keeps moving and there's always going to be better mousetraps to pick up colorectal cancer at an early stage. And I think we all realize that. When I was a fellow, right, it was CTC was the big threat on the horizon. And of course, that really hasn't changed things much, I think, for most folks. And again, there are other tests that I'm not talking about today, like PillCam colon. I mean, there's other modalities out there. But really, the world is large when you think about what's out there for us to study. We could look in blood, we could look in stool, we could look in urine, we could look in the breath with metabolomics. There's a host of factors that we can use, genetic and epigenetics. And again, so we have these circulating tumor cells or cell-free DNA, microRNA as an example, but again, people look at other types of RNA. And then we have the germline markers that we kind of know about, things like the APC gene or the genes associated with Lynch syndrome. But there's a lot of these low penetrant single nucleotide polymorphisms. There's like at least 50 of these shorter segments of the genome that are associated with colorectal cancer, and actually taken together explain a lot more of the familial cancers than the handful of these really strong genetic determinants that we know more about. And so there's a lot of information that we can look at to try to figure out who has colorectal cancer. Again, I'm also mentioning volatile organic metabolites. That again, there's been some studies about breath testing that you're probably aware of. And then how are we going to do it? And again, of course, there's improvements all the time, able to look at smaller and smaller amounts of material. But even more important is this idea of AI or deep learning. So I think our historical practice towards developing these agents, and I'm going to talk about the Septin-9 test in a minute, is really to use all the power of our science to try to figure out which is the best single marker to look for early cancer in the blood, for example. But I think we're flipping that paradigm on its head. We're now finding cases of colorectal cancer, matching them to the controls, and letting the computer, almost agnostic to science, right, figure out what are the footprints in the sand that predict colorectal cancer. Not so worried about which is the single or best marker. So again, I mentioned SEP9, and again, this slide, oh God, what a terrible slide, but part of the point of this slide is that when you think about methylated markers for colorectal cancer, right, like Septin-9 is like one of like 20 of these markers. So what's the odds that this single marker is going to predict the universe of colorectal cancer in a way? And so that's why I have this image of a needle in a haystack. This is no disrespect. I mean, there is a fabulous paper about how hard these folks worked, settling on SEP9 as the agent, validating it, and then studying it. But at the end of the day, to me, it seems just unlikely that these kind of single marker tests, particularly in the blood, are going to be all that helpful. And so you may have seen this study, this was published now years ago, where they did Septin-9 on 6,874 folks and in a screening population. And what they found is that the test had a sensitivity for cancer somewhere around 50%. And unfortunately finds a lot more late cancers than early cancers. Finds advanced adenoma basically at the level of chance, which shouldn't be surprising in a way, right? Like it's kind of hard for markers to get out of adenomas and get into blood to be detected. So I don't think that these results are all that surprising. And again, to be fair, there's different ways you can apply Septin-9. You can do 3 replicates instead of 2 replicates. That would increase the sensitivity, but actually hurt the specificity. So I don't think these single marker tests are the way we're going to go. What I do think there's a lot of activity in this space though. And this is just showing a series of the tests that are out there. So that I think there's a couple of important things in this table. And again, I'm not putting any up or any down. I'm simply showing you that generally speaking, there are combination tests looking for cell-free DNA or circulating tumor DNA, but also more than that, often looking for proteins and other markers as well. And again, the Freenome platform in particular is using AI, but the CancerSeek, of course, is using AI to tell you what test to do next. And so there's this combination of multiple tests, multiple targets, and then the computer to try to help us sort it out. I think the other thing to realize is that these tests come in two forms. So some of the companies are working on colon-specific tests. Other companies are just working on cancer present, cancer not present, right? These generic cancer tests that, I mean, probably since I'm somewhat of a purist of cancer screening, I worry a little bit about these multi-cancer, right? You apply a test, do you have cancer or not? You don't even know which cancer it is. But a couple of the groups are working on that. And then the last thing I wanted to leave you with, and again, this reference is really current. And if you're interested in this, again, this is where this table is basically drawn from. Just realize that these tests are coming, right? People are wagering here with a lot of money in a way. So, we have ongoing tests, kind of like that multi-target DNA study I showed you, 25,000 folks getting this blood test and getting colonoscopy at the same time, 10,000 for the Guardant test, right? So they are very large cross-sectional studies designed to determine the test characteristics of these devices. And again, I don't think people would be all in this way unless they felt that they can get reasonable results. And as a side note, the FDA has established some benchmarks for performance of these tests. I think it's for them to approve it, I think it needs to have a sensitivity for cancer of at least 74% and a specificity of 90%, and then be recommended by one of the organizations. So the FDA is kind of getting out front, setting up the ground rules for how they're going to consider these results when these studies are published. And these are going to be coming to New England journals near you, I suspect. So I'm going to leave you with not New England Journal data. This is an earlier result from the first row of that table. It was a mixed population study, 591 prospective average risk screenees. But again, just like in the abstract, it's hard to get enough cancer cases to make this worthwhile. So they enhanced the cohort by adding people from a case control study with cancer. So ultimately, again, just like in that abstract, right, you have very low numbers of cancers that you're dealing with here, but they were able to accomplish with this approach about a 92% sensitivity for those 17 early cancers at a specificity of 90%. So again, this is not average risk screening. I do not expect that the 25,000 person study will have data that's this rosy, but you can see the direction that this is going. And then my very last set of slides is just about this. You may have seen this again. This is not totally new. This is one of those multi-cancer tests. So I showed you one of the Freenome products is a colon cancer specific device. This were the results that were published in Science a few years back about that CancerSeq device. So it uses PCR-based assays to assess multiple regions of driver genes, so circulating tumor DNA, combined with an immunoassay platform of 39 proteins, right? So they're using something about genes, something about proteins, and they applied this tool that they had validated in 1,005 non-metastatic cancer patients and 812 healthy controls. So how did it do? And again, I think this made a fair amount of buzz when this was initially published, but you can see here that, and again, this is the ROC curve. And again, this is for cancer up, cancer down at a specificity of like 99%. It had a sensitivity for cancer, any cancer, of about 60%. Maybe somewhat disappointingly, it was harder to detect early cancers, but the sensitivity of this particular test varies depending on which organ you're talking about. And the way the test works is when the result comes back, if it comes back positive, they know which proteins, which driver genes are positive. They then help you try to manage the patient by saying, hey, I think the next best step would be a CT scan, or the next best step should be a colonoscopy. And so that's how they're using the data from the study to try to help move the care of the patient. Because again, just knowing that someone has cancer, you can imagine the implications of that, both from an insurance perspective, but also from a concern worry perspective, and the kind of workup that's going to follow a positive test like this. All right, so my last slide in conclusion, colorectal cancer screening works. I showed you randomized controlled trials. All major guidelines support starting screening at age 45. The benefit's relatively small. Be aggressive about case finding and searching for family history. You have options for screening. FIT and colonoscopy are the tier 1 options, according to the U.S. Multi-Society Task Force. Again, I think the future of screening is bright. It's close, not quite here, but I think in 3 to 5 years, I think some of these blood tests are getting that close. So improvement in current tests, personalizations, and then these new blood test options are on the horizon. Thanks so much.
Thank you for another outstanding talk. Before we get to questions, and I do want people to come up and ask some questions, I just wanted to tell you we're going to have a nice long lunch break, but there is a sponsored luncheon. I think Janssen is sponsoring a lunch. So please attend that. Please go to the galleries and visit with the people who are doing exhibitions. There's a raffle once again. I think a $200 Visa gift card is on the line. So somebody here is going to win that. And please remember to log in online or use the code and complete your surveys for CME, MOC, and also so we can make this course better next year. Tell us what you liked and what you didn't like. Dr. Ashby's back again.
Really enjoyed your talk very much. You talked about when to start screening, and there are recommendations on when to stop screening currently. I was curious about your own approach to when to stop surveillance in patients that have polyps. Do you base it on 10-year life expectancy, et cetera, et cetera? And if so, how do you discuss with the patient in the room that your 10-year life expectancy is not that great?
Very good.
Practical standpoint.
Yeah, very good question. I mean, like most gastroenterologists, I'm probably protected, right? Like I am not there at the focal point when those decisions are often being made, but I do going into the colonoscopy. If I'm doing an endoscopy on someone who's had a lot of low risk adenomas, they're in their 70s, I'm often preparing them for the idea that in my estimation, I would stop screening. If they're going to be 80 and older, they've only had low risk adenomas, my bias is not to continue surveillance. And so I prepare them for that idea before I make them sleepy. And then of course, again, they go off into the Ethernet after the test, and then I'm sending them letters. To your point, I guess I'll just say two other things. We just published, Dr. Audrey Calderwood and I just published a commentary in Gastro about this topic in a way and how we can improve making surveillance recommendations in older folks. So please take a look at that. It's more than I could say in the 1 minute I'm responding. And then finally, I am part of a clinical trial with Audrey Calderwood and TR11 who are leading it, where we're going to compare, yes, of course, colonoscopy and FIT in older adults with a history of adenomatous polyps. So we are funded by PCORI to do a randomized control trial of colonoscopy and FIT in older folks with a history of polyps, kind of extending this idea that, again, people with 1 to 2 low-risk adenomas are really a low-risk population and probably don't need continued ongoing colonoscopy.
Yes, sir.
The problem of you've done a great colonoscopy and then 3 years, 4 years, 5 years, 6 years after the fact, somebody in primary care orders a FIT that comes positive. And they're not doing it because they're symptomatic or because there's a family history, because they think they're practicing good medicine. So we run into this problem all the time. So I wonder how you guys handle it.
Yeah, it's covered a little bit in that FIT. I mean, I show that one slide briefly, the US Multi-Society Task Force paper, and we talk about this circumstance. The bottom line is it's really hard to walk around a positive FIT. And so almost exclusively relatively healthy people, and that includes a lot of people, I'd be repeating the colonoscopy. I don't know how you work around that. Of course, there's extenuating circumstances. You know, they have some other life-threatening illness that's going to bail you out. Of course, you can have a shared decision-making discussion with them and talk about the risks. I normally say if I've done the colonoscopy, and this is a little bit picking numbers out of the air, you know, it's probably like in the range of 1 in 100 or maybe a little less that you have cancer, you know, if you want to take that chance. But I think it's hard in today's environment to walk around a positive FIT. That's what I think.
Dr. Menz.
Two things. Number one, the worried well. That's a subsegment of the population that needs reassurance. And there may be minor benefit for a colonoscopy for some of those individuals. The other part of the totally different question, and that is, as one gets older in their 70s and beyond, the biological false positivity of colorectal cancer markers goes way up, correct? And did you want to address that?
Sure. I mean, I think it's most well recognized for methylation. There's clear evidence that methylation increases with age. So to the extent that testing relies on methylation markers, which the Cologuard test does, the test characteristics, you're going to have more false positives. So I think you're right, but not right. Not all the markers we're looking at are methylated markers. So your point's well taken for the methylated markers. Yeah, I guess I'll leave it there since we have a couple of other questions.
We're going to go to my left first. Yeah.
Oh, thanks for your great talk. Calvin Nguyen from Kaiser Orange County. Sometimes you do colonoscopy, you say, come back in 10 years, I don't find anything. And you have a question, the patient asks you, are you sure within that 10 years, you're not gonna, something's gonna develop? So there's some data actually doing non-invasive interval testing. So cooperating, after colonoscopy, maybe consider doing interval fit test, in 5 years. And that was some data that would show some benefit to it. So what's your take on that?
Yeah, I think I have to hold to the party line that if you're doing, I totally understand your point, but I do think as a society, I mean, as a society of gastroenterologists, we do need to indemnify our high quality colonoscopies for 10 years. You're right. There's certainly data or interest in looking at interval fit testing. I think more from Australia. I'm not familiar with a lot of US abstracts or papers on this. But I think, I mean, in my practice, I guess as many of yours, that you have to live with that high quality colonoscopy. That being said, I think it's incredibly important, like your documentation about the colonoscopy. I also think prep is incredibly important. Obviously, I'm not covering that today. I personally use the Boston Bowel Prep. And so I'm going to use that 10-year interval only when every segment of the colon is at least a 2. I would not feel comfortable doing that if I had a lesser prep. So again, got a picture of the cecum. I have a high quality prep, no findings. I am going to live with that 10-year rate. But you're right, some small percentage of people will have cancer. I do think from a medical legal standpoint, I think you'd be fine, right? I mean, I think many years ago, the American College of Physicians actually had a campaign and basically promoted this idea that your interval should be 10 years if you have a normal screening colonoscopy. I think that's pretty well worn out, but your point's well taken, but I think I would indemnify that 10-year window.
Thank you. That's a great talk. I'm just wondering if you could expand on the difference between the multi-DNA stool test versus FIT.
Yeah. Yeah, so again, I tried to cover it a bit in the talk. Just a reminder that the multi-target DNA test is just that, right? So you collect the whole stool and they're doing actually these DNA markers, but you're also doing a FIT test. And it's not the Polymedco OC sensor FIT test, it's a company FIT test. So you're poking the stool as well. And then they are taking the data. So when you order that test, you don't know what's driving the positive result. You don't know if it's the DNA markers. You don't know if it's the blood in the stool. It's some combination of those levels that drives the positive test. And the company, it's FDA approved to be used in that way. So they, unlike that last cancer seek, they can't tease out or tell you, oh yeah, it was the stool DNA that was positive, or no, it was just blood in the stool that was positive. You just have to live with that positive result. And I think that is going to lead. I mean, we actually have a grant where we're trying to look at enhanced testing. I think practitioners, primary care doctors, but probably gastroenterologists too, are more worried when someone is excreting, stool DNA. And I think the follow-up is probably closer. And I bet you more people get EGDs as well, things like that. So I don't know, that's how I'd expand upon it.
So the result that you showed that there was only one improvement in one patient when you compared the FIT versus the multi-DNA test, that wasn't like Cologuard, that was just strictly.
No, that was that's the multi-target DNA test there is only one. I mean, that is the test that the U.S. Preventative Services Task Force is looking at. So it was a difference. It actually favors FIT. The U.S. Preventative Services Task Force models favor FIT annually over multi-target DNA testing every 3 years. At least I would read it that way, although they say either one is okay. But that's the data comparing FIT to mtDNA. But there's big caveats there. The U.S. Preventative Services models are assuming 100% FIT adherence. They're assuming 100% multi-target DNA adherence. They're assuming FIT to colonoscopies 100%. Right? I showed you data about adherence, right? It's not perfect. And so the company, Cologuard, would say that in the absence of real world data, it's hard to trust these models, and that actual real head-to-head clinical trials need to be done comparing tests like FIT and the multi-target DNA test.
I'll get to you, center microphone first.
Thank you, Dr. Robertson, for I commend you for looking at the effectiveness of a colonoscopy, because it is something we take for granted. And I think it's helpful when we have this discussion with other disciplines, and especially when you're working with residents and students and fellows. I want to get your comment on, I don't know if you mentioned that in your slides, I might have missed it. The Italian study that was published in the Annals of Internal Medicine in January regarding that follow-up of the RCT done in Italy, as far as the effectiveness of flexible sigmoidoscopy, that when they had two arms looking at control, which is usual care, versus flexible sigmoidoscopy, and it showed benefit of flexible sigmoidoscopy in prevention of CRC up to 17 or even 19 years. So I want to get your opinion on that.
Yeah, I'm familiar with that trial. I think, if I remember correctly, there's a big difference in adherence in a way. And I actually think there was more effort towards adherence in the flexible sigmoidoscopy group relative to the comparator. So I think that there are, again, one message that I didn't probably make loud and clear, right? The single most important thing about screening is adherence. And so I think if you look at that study and you look at the opportunities to be screened, yes, there's a difference between the groups, but I think there's higher adherence in one group relative to the other group. That's what I remember off the top of my head.
There was one more question.
Yeah.
Yes, I'm just going to repeat the question. The question was that there was some concern on the part of consumers that maybe when a Cologuard test was submitted, the methylated DNA portion of the test was only run if it was positive, which I don't think is true, but.
Yeah. I mean, I think they're transparent about there's a paper in CGH. I can't give you the first author and year where they describe the methodology, and clearly it's a logistic regression model using the DNA and the fit. So I don't think they're only doing the fit. That being said, in an individual person, it's certainly possible that only the blood portion of the test is driving it. You don't even know on an individual patient, right? Like I'm telling you, if you do the OC sensor, what the level of blood is, you don't know what level of blood the person had in their stool and how that played with the markers. But I do think they're doing the full, it's approved as both tests. It's the combination of the DNA and that stool blood. So I'm sure they're doing both tests.
Okay, Dr. Ashby, last question.
Regarding Cologuard, if I'm not mistaken, the sensitivity is like 92.7% for CRC, but the positive predictive value for colon cancer is only about 4%. So, and I don't think that the referring doctors, the family practice doctors, internal medicine doctors that refer to us know that the PPV for Cologuard is 4%. So patients come to us with a positive Cologuard worried that they have colon cancer. Do you have any recommendations on how the internal medicine family practice doctors could be better educated in terms of what a positive Cologuard really means?
Right. Yeah, it's a great point. And I'm trying to remember why I wrote the commentary, but there's a commentary. It's in CGH, Dr. Dominance and Robertson, but I think I'm the first author on it, where we actually have a table where we think what information should be given to patients before they accept Cologuard. They should understand something both about the sensitivity, the specificity, positive predictive value. So there's a table in there trying to highlight that exact information, that even when your test is positive, your colonoscopy is only going to show a cancer in a small percentage. Because again, my fear is that there is a lot of follow-up work that's done. People get EGDs. People don't use the 10-year window. Oh, he was positive on his Cologuard test, even though the colonoscopy is negative. I'm going to bring him back in 5 years. I fear a lot of that's going on. So we actually have a little table. If you can get your PCPs to look at it, that would be a great outcome of the commentary, because we did it for that reason. It's such a practical question.
All right, we put you through enough. Thank you so much.
All right, thanks.